Thank you. So the first hot topic was about surgery. So Stephen covered that very elegantly, so I'm not going to touch on the question of surgery, but we'll discuss several aspects of systemic therapy. So these are the current guidelines, these ESMO guidelines. And if you just had one look, you say, oh, there's way too many options there. How do I pick for my patient? How to decide on the best systemic therapy for each patient? And so I'm heading back to the question of biomarker. Can we have a pragmatic approach to guide us for systemic therapy? One is sarcomatoid component. Check on your path report. Any sarcomatoid component is actually helping us to go for a doublet IO strategy, namely nivolumab plus ipilimumab. Another one is gene expression profiling, and there has been a lot of work that has been conducted. The way was paved by the ImMotion program, where they were able to identify different subsets of renal cell carcinoma, and this is only clear cell RCC. So they don't have the same biology, and is that something we could use to decide on treatment? And the good news is that, yes, it's doable. There has now been reported 2 trials which look at the biology of RCC using gene expression or surrogate of gene expression profiling to randomize patients. So it's doable, but one caveat is that it had to be fresh, frozen tissue, which ultimately is not applicable in routine practice. The most recent one that was reported is the optic RCC. It was presented at this ESMO, and here it's a small phase 2, but the rationale is the same. Can we define the biology of the tumor so that we allocate the best treatment? And so it's not a phase 3, it's not randomized, but based on the clustering that was defined by the tool they had developed, they would say, okay, if the patient has more VEGF, angiogenic-driven tumor, we want to go for IO-TKI. And so they had an ambition that they could have a response rate extremely high, over 60%, and they indeed reached that. But the caveat here is not about frozen sample, because it wasn't frozen sample, but it's how do you perform the clustering next day in clinic? I cannot do that. Who can do that? Okay? So ultimately, we need a biomarker that is pragmatic, applicable for each patient. So I'm going to get back to PD-L1 I mentioned earlier. And so PD-L1 is a biomarker of interest in metastatic kidney cancer. We have several trials that reported which showed that this biomarker, when you look at tumor cells, seems to enrich for response to the combination of 2 immune checkpoints, nivolumab plus ipilimumab. And here we had first the CheckMate 214. If you look at the curves, this is what we call a predictive biomarker. You don't have it, the curves overlap, you have the biomarker, you see a benefit of your treatment. And we have the same signal in the adjuvant, I mentioned that earlier, as well as in non-clear cell, that's the SUNny forecast. So different trials. And if we put that in a table, what I'm showing you here is that PD-L1 is likely to be associated with higher benefit of nivolumab plus ipilimumab. So this is across the different trials that looked at combination regimen in first line and the magnitude of benefit versus sunitinib. And the hazard ratio for overall survival is the highest for nivolumab ipilimumab in the patients that are PD-L1 positive, and it's the reverse hypothesis or reverse observation in the PD-L1 negative. And that led to this study, and the reason I'm mentioning that is that right now I'm trying to have this study coming to Turkey so that you can take part as well, is that patients in frontline metastatic disease could be stratified based on their PD-L1 expression and randomized between IO-IO and IO-TKI. So basically, we make the most of existing treatments, so our patients receive the treatments that are the most interesting for them and have achieved a higher benefit. Now I'm going to mention one word about microbiome, because in any conference, everyone speaks about the microbiota. Actually, RCC is among the first tumor where it has been investigated, because looking at retrospective data, the scientists in this field, especially Lisa de Rosa and Laurence Albiges, identified that a gut dysbiosis is associated with different response in patients treated with immune checkpoint inhibitor. And they looked then at what they called the composition of the stool, so each one of the species, and they could identify those that are good ones and those that are bad ones associated with worse outcome. The great thing is that in the US, our colleagues were able to prospectively demonstrate the added value of implementation of live bacterial. So basically, patients were treated with combination therapy, either IO-IO or IO-TKI, and were receiving in a randomized way a supplement, a bacterial supplementation. And in the two studies, demonstrated a higher response rate for those patients that were receiving the bacterial supplementation. So clearly, very easy to do, bacterial supplementation, increased benefit of immune checkpoint. Another thing that we saw was fecal microbiota transplantation, and this is done in Italy, but also now in several studies across the world. And this is frontline study, RCC patients were receiving IO-TKI, and then they were receiving an FMT or placebo. So they were randomized. Please bear in mind that the FMT required colonoscopy, so this is clearly invasive strategy, and everything was relying on a single donor, one donor, for the entire trial. But what they were able to show is that there was a clear increase in response rate and progression-free survival for those patients randomized to the FMT strategy, and the donor was a patient that had major response under doublet IO in first-line setting. So very interestingly, this is a proof of concept. Now the question is, how do you apply that at a broader spectrum? And you have to basically generate things that will not require colonoscopy and that would not rely on one single donor, of course. So this is the key findings, almost a doubling of the response rate, including a very long, prolonged progression-free survival. One word on what we call the tumor gut axis, MADCAM. The reason why I'm mentioning this biomarker is that it seems that MADCAM is a soluble biomarker that can serve as identifying those patients that have gut dysbiosis, the one for which the gut is not in a good mood and that will require fecal transplantation or probiotic, any microbiota-centered intervention. So it could be a screening strategy where you test on the blood and say, okay, this patient is fine or this patient has a dysbiosis and need added microbial intervention. So this is a screening tool that is currently being developed. Now, switching gears to the question of how do we treat patients if they relapse after adjuvant. So first-line metastatic setting, my patient has received pembrolizumab adjuvant. How do I treat the patient? This is the table I've shown you. These are the ESMO guidelines. Is that applicable in post-adjuvant setting? Well, we have very few data, and these were generated by the IMDC consortium. It's a retrospective study. Patient had a recurrence after adjuvant immune checkpoint inhibitor, not even 100 patients. And it's interesting to see that the way the patients were handled was very heterogeneous. It could be single-agent TKI, it could be combination with an IO backbone, either IO-TKI or IO-IO, or it could be focal treatment, because we don't know how we should treat a patient that fails adjuvant. And how do we define failing adjuvant? There has been several algorithms that were presented to define what is refractory. Is it within 3 months of adjuvant? Is it within 1 year? This is the EAU guidelines. What we define for this one is that a refractory is someone who has disease progression within the first 6 months under treatment. The intermediate is someone who has a relapse under exposure or in the 6 months right after the adjuvant, so overall 18 months. And basically, this patient population, they did not derive benefit from the pembrolizumab. So these are refractory, real refractory patients. So here the recommendation, but it's more an expert opinion because we don't have randomized data, is to go for single-agent TKI. It's useless to have a backbone of PD-1 inhibition sustained. But if my patient has a rather later relapse, at least 6 months after the end of adjuvant, then potentially it means that there was a role of my pembrolizumab in postponing the relapse. And here, the expert opinion would say, let's try to re-challenge with an IO backbone and more likely to be an IO-TKI. Now, what about second-line therapy? So these are the current guidelines, focusing your attention on the bottom of this algorithm. What I can tell you is that it's no use of using ipilimumab, the CTLA-4, in late lines because we cannot induce complete response and we don't have a high response rate. So we sequence the TKI but not the CTLA-4. The second is there a role of sustained PD-1, PD-L1? And it's a bit the discussion we were having in adjuvant. There is 2 large randomized phase 3, both of which has reported. One was comparing cabo plus or minus PD-L1 atezolizumab, and the other one was tivozanib, it's a potent TKI, plus or minus nivolumab, PD-1 inhibitor. The 2 studies read out in Lancet, but the 2 studies are negative. Why did they read out in Lancet while it's negative study? It's because it's a proof of concept. Re-challenge in an IO refractory is not working if the patient was really progressing under treatment. So we should not be using PD-L1 or PD-1 inhibitor in a refractory patient. Is there a chance we can still combine treatment in late lines? And this is a study, LIGHTSPARK 11, which look at cabozantinib as one of the standard of care versus lenvatinib, another TKI, on which we have this HIF inhibitor that we were discussing earlier. Why is it interesting? Well, we have data from phase 1 showing that the combination of lenvatinib plus belzutifan induce high response rate and long progression-free survival. So it means that targeting the HIF VHL pathway upstream and downstream with a potent HIF inhibitor and a potent VEGF TKI seems to do better than single agent. And this was only through a phase 1, but last week, here again, we had a press release that this study is positive. So there is a chance that we're going to change our standard of care in second line based on the benefit of the added value of belzutifan on top of lenvatinib. I know it's going to take time. In France, I don't have access to lenvatinib. These are very costly drugs, but we're making progress. And the question is, when should belzutifan be used? Is it earlier, I said in adjuvant, or is it there in refractory setting? I'm going to say just one word about non-clear cell because this is a hot topic for medical oncologists as well. We discussed the question of cytoreductive nephrectomy in non-clear cell. What about systemic therapy? So as you know, it's a mixed bag of different entities, among which we have translocation carcinoma, papillary, chromophobe, but also even more rare tumors, such as collecting duct or renal medullary. The good news is that our pathologists are getting better at defining these entities with molecular defined entities. But the question is, how do we treat them? And there has been 2 studies that combine IO plus TKI, so the 2 strategies we're using in clear cell. The good news is that the strategy of combining one broad-spectrum TKI, such as cabozantinib, plus one PD-1 inhibitor, nivolumab, does induce deep response. And the study that is the largest is a study which combined lenvatinib plus pembrolizumab, so broad-spectrum TKI plus PD-1. And here again, across the different tumor types, including papillary that are tough to treat, unclassified translocation, we induce deep response, which we didn't have with single-agent approach. And so that really changed the game for our patients because we now have patients that are responding. We used to say in my tumor board, it's a papillary relapse, lymph node disease, we should go for surgery because they don't respond to systemic therapy. Now we're not saying that anymore. We're saying, okay, we know the patient can respond to combination therapy. Should we start with that? And ultimately, potentially even discuss a closure surgery strategy. So my take home on this is that we don't yet have biomarker, here again in routine practice, but we need something that is applicable, and PD-L1 is one of them, at least being tested. If our patient is not cured in first line, we won't cure the patient in second, third line. So we need rescue strategy post-immune checkpoint inhibitor. We need randomized study, and we have more and more study there. We don't yet have a favorite TKI, so you can use cabozantinib, lenvatinib based on what is available. And the sequence trials are very hard to do, and so this is where we need real-world data to build our confidence on our overall strategy. And with that, I would like to thank you again for the invitation and your attention.